Debelina, you're muted. Debelina, you're muted.
Okay, I'm so sorry.
Unmute.
It can happen even to Debelina, so imagine.
Sorry, so sorry. So a very good evening and a warm welcome to one and all present here. This is Debelina from Planet Side. We are very much proud to be a part of this webinar as a digital partner. So without further delay, I would like to play a short video of Planet. Planet is India's largest live digital CME and a doctors-generated medical content platform. So now with all of you, I'm going to share the short glimpse of Planet. Thank you so much all for your patience. You can find us on Google, which is www.planet.com. So now, without further delay, I would like to hand over the session to Dr. Dolly Fatima, who is Assistant Professor, Department of Biochemistry at JLN MCH, Bhagalpur. She is consultant gynecologist at Arogyam Hospital at Bhagalpur. Ma'am, over to you to start with our today's program.
Thank you, Debelina. So a very warm good evening to one and all. It is indeed an auspicious occasion to witness such great star was present for today's webinar. Bhagalpur Menopause Society is really indebted by their presence. I welcome all dignitaries present today. I would especially like to welcome our President of BMS, Dr. Pratima Singh ma'am, and our Secretary, Dr. Archana Jha ma'am, and thank them for all the efforts they have made for arranging this webinar. Dr. Pratima Singh ma'am needs no introduction. I would like to take the privilege to introduce Dr. Pratima Singh ma'am. Develina, can we have the slide? Yeah, thank you. No, slide of Dr. Pratima Singh ma'am. Dr. Pratima Singh ma'am is MBBS, MD, FICOG, CIMP. She is consultant laparoscopic gynecologist and IVF specialist. She is the director of Healing Touch Multi-Speciality Hospital and IVF Unit, Bhagalpur.
Everybody knows.
Can we move? Okay, she has the honor of giving the first IVF baby to Eastern Bihar and Jharkhand, and she has many more achievements to comment on. So I welcome you, Pratibha ma'am, and I would like to request you for your welcome address.
Thank you, Dr. Roli. And good evening, everyone. And I would like to welcome all of you to this IMS Presidential Webinar Series. And I would like to thank our President IMS, Dr. Shobna Mohandas, Madam, for giving us this opportunity. So thank you so much, Madam. And first of all, I would like to welcome our Chief Guest, Dr. Meeta Singh, Ma'am, Guest of Honor, Dr. Ambuja, Madam, whose blessings are always with us. And I also want to welcome our Dr. Pushpa Sethi Madam, Dr. Anjana Chauhan, Dr. Neela Mohri, Dr. Beenal Shah, who are the chairperson for the different sessions. And today we have a focused webinar on breast lump, which is a very common entity. They are most often either fibroid or cyst, or sometimes just a normal variation in the breast tissue. Other causes mainly include breast cancer, which should be diagnosed on time if you really want to save your patient. So today we have a learned faculty who will be talking everything on breast lump. And first of all, I would like to welcome our very senior member of IMS, Dr. Rama Vaidya Madam, who will talk on how and why there is a need to establish a specialized breast cancer care center which can add new dimension in managing breast cancer patient more efficiently. So welcome, Madam, to this forum, and thank you so much for giving us this opportunity. Our next talk is on HRT and breast cancer, and Dr. Shobna Ma'am will be throwing light on this topic. So welcome, Madam, to this forum. And then we will have a panel discussion on breast lump, and our moderator is Dr. Anju Soni Madam. So welcome, Madam, to this forum. And I also want to welcome all our worthy panelists, Dr. Ragini Agrawal Madam, Dr. Amrita Jaipuriar, Dr. Shubha Sethia, Dr. Leena, Dr. Anupma Sinha, Dr. Basundhara Lal. So welcome to this forum. And I also want to welcome our Secretary of Bhagalpur Menopause Society, Dr. Archana Jha, and the Master of the Ceremony, Dr. Roli Bharti. Now, It's my proud privilege to introduce our chief guest, Dr. Meeta Singh ma'am, a well-known personality, a lady with great academic excellence. And ma'am, I silently admire you that how meticulously you are involved in research work and how passionate you are about academic work. So welcome, madam. And she's co-director, Hospital Hyderabad, editor-in-chief in Journal of Midlife Health 2020 and 22. She was president IMS in 2012. She has edited many books and published many papers, and her area of interest is menopause, osteoporosis, and gynec ultrasonography. So with this word, I will request madam to please bless us with some pearls of wisdom. So over to you, Meeta madam.
Yeah. Thank you so much, Pratibha. Thank you, all of you, dignitaries on stage, Dr. Rama ma'am. It's always a pleasure. And Pratibha, you always come out with such focused meetings, which are very, very interesting. And I think Shobna's President's webinar series are really doing a great job. You know, the tempo and the flow is something like what was there during the COVID times when the virtual webinars had started, that there is one talk. And based on that topic, you have a nice panel discussion. So it completes the picture and you have all the opinions from everybody and the base is all set. But today is something very, very special. And I think this topic is very nice because I had the fortune to have started that a thoughtful, in the Journal of Midlife Health, a new section where Dr. Rama and Dr. Ashok Vaidya had sent their, I had requested them that they have to send in something very, very important before I retire from the editorialship. And this was one of the topics which she has discussed in that particular, in this Journal of Midlife Health January to March issue. So it will be really great to hear more about it from ma'am, because just like this menopause concept and menopause clinics concept, this is something which needs to be popularized because all of us know that breast cancer has surpassed cervical cancer in India. Thank you so much for having me in. It's a pleasure, ma'am. Dr. Raman, Dr. Pratibha, Shobana, Dr. Ambuja, and all the dignitaries and all my colleagues who have joined us today in spite of everybody's busy schedules. Thank you so much.
Thank you, madam. Thank you so much for joining and sparing your valuable time. Over to Dr. Roli.
Thank you, Pratibha ma'am. Do we have Dr. Archana Jha ma'am with us today?
Yes, she's there.
Yeah. I welcome you, our Secretary of BMS, Dr. Archana Jha ma'am. I take the privilege to introduce our Secretary. Dr. Archana Jha ma'am is MBBS Gold Medalist, MBBS. She is Associate Professor of Bhagalpur and Fellow of AMS IMA Chairman, AMS IMA Bhagalpur. She is the first Honorary Secretary, BOP, Vice President of BOP Bhagalpur. Presently, she is Secretary General Bhagalpur Menopause Society Bhagalpur. So I welcome you, ma'am, and I would request you kindly to introduce our guest of honor, Dr. Sri Ambuja ma'am.
Hello.
Archana ma'am.
Yes, Archana, we can hear you. Hello. Unmute yourself, Dr. Archana. Please unmute yourself. Yes.
Hello.
Yes, we can hear
Good
you.
evening, all. It is my pleasure to introduce our Chief of Guest, Ambuja Madam. May I have CV, please?
Don't read all the CV, just you say one word, that is enough.
Ambuja ma'am, we are very much appreciate you, and I think it is on the cover your CV, but as I know and we all appreciate your beautiful personality, your beautiful views for menopause, and for our fellow colleagues to be active and be the important have to play important role in menopausal ladies. And as
you have to unmute.
Archana, I think you are muted.
also
Unmute yourself.
Yeah.
hello.
Yes.
And thank you very much, everybody. Good evening to all of you. I'm immensely happy that I made a part of this President's webinar. Shobna, I really appreciate you for such a wonderful program which you are doing every Tuesday with different topics. And what we never imagined that they can be included in the Menopause Society. And equally, I congratulate Pratibha for executing whatever you told. Organization is really important. And first question, what you asked, does India need specialty breast cancer center? Wow, wow, it is really important to ask, especially Madam Vaidya has to answer this. Yes, madam, we are all ready to hear from you. Any question if you ask, starting a girl from 15 years to a lady of 80 years, what you are scared? The first answer they will tell is we are scared about the breast cancer. Always it is there. But probably the mortality has come down. Hats off to Indian Menopause Society. We have created lot of awareness by campaigning and early detection. Yes, definitely it has come. So, madam, we are going to hear from you. And about the MHT, what Shobna is going to talk. We are talking about MHT since years from the time we entered. But you know what Chief Investigator Professor John Manson about the WHO chief is, what he told is, after the 15 years of WHO study, what words it came out, the big concern in clinical practice is it's not the overuse of hormones, it is the underuse of hormones. Equally, the doctors are scared and the patients are scared. It is up to us to see that that scare goes away and we will try to use it properly. That's what is really very important. Third topic, really, I'll tell you how it is important. Interesting, that is evaluation of the breast lump. It is none other than Dr. Anju Soni is dealing with it. And all very important topics. I'm really thankful to the organizers for giving me the opportunity to be guest of honor for today's session. Thank you very much.
Thank you, madam. Thank you, madam, for sparing your time. Thank you. Over to Dr. Roli.
Thank you, ma'am, and I welcome all the dignitaries once again. So, should we move to the scientific session?
Yes.
So, we are moving towards scientific session, and we will begin with the first session, which includes a discussion on does India need a specialty breast care center? This is really an interesting topic, and to speak on this topic, we have a very dynamic speaker with us.
Roli will make it short.
Just a minute, Roli. Just a minute.
Yes.
Just a minute, Roli. I just want to welcome Dr. Seema Sharma, madam, also, who has joined here. She is Secretary General IMS. So, welcome, madam. Welcome, madam.
Good evening, everyone. I just got a little bit late. So,
thank you. Thank you so much for joining, madam. You came. Thank you. And we'll be starting our session now.
Madam.
Good evening, madam. So we will begin with the first session, which includes the topic is does India need specialty breast care center? This is really an interesting topic, and to speak on this topic, we have a very dynamic speaker with us, none other than Dr. Rama Bhagalpur. I welcome you, ma'am. I would like to request Dr. Pushpa Sethi and Dr. Anjuna Chauhan, ma'am, to kindly chair the session. I welcome the chairpersons and the speakers. I would like to take the privilege to introduce our chairperson, Dr. Pushpa Sethi, ma'am, is a senior practicing obstetrician gynecologist at Gurgaon. She is the director of Sethi Hospital, president Indian Menopause Society, and organizing chairperson IMS Con 2018. She is the vice president of Indian Menopause Society, secretary general of Indian Menopause Society, chairman Midlife Management Committee from 2016 to 2018. She is the recipient of Lifetime Achievement Award by IMA Gurgaon And she has also done a very too many social work. She initiated breast cancer screening program, thalassemia screening program, anemia eradication program in adolescent girls in association with Rotary. In COVID time, she has worked in close association with Rotary Blood Bank Gurgaon for making plasma available for the needy patients. I welcome you, ma'am. Our next chairperson is Dr. Anjana Chauhan, ma'am. I welcome Dr. Anjana Chauhan, ma'am, also. Can we have the CV of Dr. Anjana Chauhan, ma'am? Yeah. Dr. Anjana Chauhan, ma'am, is consultant gynec cancer surgeon at Radiance Hospital, Ahmedabad, Gujarat. She is the director of Anurika Empowerment Foundation, ex-associate professor, GCRI, Ahmedabad. She is the president of Ahmedabad Menopause Society, ex-committee member AOGI, ex-managing committee member AOGS, and member of AOGS, AOGI, AOGIN, ISCCC, IMS, IHPSN, IMA. She has received the Best Paper Award, second prize HTMH Mumbai, Dr. T.V. Patel Young Research Scientist Award GCRI, and has published more than 30 papers in national and international journals. So I welcome Dr. Anjana ma'am. Now I would like to request Dr. Pushpa Sethi ma'am to kindly introduce our speaker, Dr. Rama Vaidya. Ma'am, please introduce our speaker.
I can't hear you.
We
You are
cannot
not
hear you,
muted.
madam.
I don't know. Try again. Are you speaking having a headphone on your computer? Now unmute yourself. Still we can't hear you. No, we can't hear you, Pushpa.
Let Anjana introduce.
Okay, let Pushpa conclude. Let Anjana start. Pushpa, you are not audible somewhere, so I don't know what went wrong.
Dr. Anjana, madam, please.
Hello, good evening. Am I audible?
Yes,
Yeah.
yes.
Yeah, you are.
Hello, am I audible?
Yes,
Yeah.
Yes, you are audible.
Yes, I just thank the Bhagalpur Society for inviting me for this webinar. And it is my privilege and proud to what we can say about ma'am. Ma'am is such a great personality, a founder, what president of our Menopause Society. And madam is going to give her inputs, her long, we can say, her experience about, I think in those days, breast was never given so much importance, but madam's long experience, we will be hearing from her. She is a MD, PhD, DGO, and Research and Administrative Council, Kasturba Health Society Medical Research Center Director, Division of Endocrinology and Metabolic Disorders, KHS, MRI, Parel, Mumbai. Madam, please, we want to hear from you regarding this topic, and we welcome you for the talk. Hello.
Thank you. Thank you.
It is a privilege for my to ma'am introduce you. The words are less for you, and you are a magnanimous personality.
Well,
What to say about
well, no, not at all. I'm so glad. And first of all, before I thank anybody else, I think that I would like to thank Shobna. She has really galvanized these webinars. And these webinars, when I go to the list,
Madam, you are on mute, madam.
Dr. Rama, you may be unmuted.
You are again muted, madam.
okay. Is it better now?
Yes,
Yes.
yes, you are
Yes.
audible.
I was just saying that I have to address to so many people whom I know here, and they're all dear to me. And Shobna particularly has galvanized this webinars. And somehow she attracts me, she finds it out and she attracts me to be a part of it. What has
Thank you,
happened is that
madam.
Dr.
Thank you for
Pratibha
coming.
Singh very kindly talked to me and said that we need your blessings. And I think that I always remember what is the name of Lata Mangeshkar's sister's name? What is her name? I'm forgetting.
Asha Bhosle.
Asha Bhosle.
Ah, Asha, right. When she was getting a Lifetime Achievement Award, she said, I hope that this does not mean an end to my singing. And I would want to say the same, that we need to learn, continue to grow, no matter what. So then partly Meeta did give out that what is the genesis of today's talk. So before I go to my title slide, I would say the genesis of the talk, the culprit is both Shobna, Pratibha, and Meeta Singh. And Meeta invited us to write something. Dr. Ashok Vaid is very fond of a convergent and multidisciplinary integration for research. It could be any topic in internal medicine or in reproductive medicine. So he specifically wrote about research in menopause. And here we had also written a little bit about Asha Kapadia when we were talking about the cancer care, that how supportive that Mahek was. And I know that I used to send my patients for that kind of a support that she had created. An medical oncologist, she beautiful. So next slide also shows the basis of the talk now. Genesis of the talk is the convergent research is generally inspired by a need to address a specific challenge or opportunity, whether it arises from deep scientific questions. Very important. You may have some scientific question, that's why you may do convergent research, or it may be pressing societal needs. And I think there is a societal need, all right. Two important areas that came to my mind while we were shaping this article, and I was very excited. And I used to keep talking to Meeta about it. And then we were equally kind of engaged into these two areas, talking about it, specialized women's heart centers, the gender disparity in cardiac care. This also is a very important, if you ever go through this article, you will find the cross references, which says that there is a not only gender disparity in the cardiac care because of the gender disparity, but there is also a need for a specific cardiac care for women because women's heart is different, it behaves differently. Specialist breast cancer clinic, the requirement, composition, accreditation, certification, and audit. I was very much attracted to this particular area and one particular article, and I'll come to that little later. See, but also once I was talking to, I think, Dr. Ambuja, and Dr. Ambuja and I, we were talking about the menopausal health clinics. I was just saying that we should define the requirement, composition, accreditation. Without accreditation, we should not, because the composition has to be appropriate, certification, and the audit. Now, this could be standardized. That does not mean that we should discourage anybody to open a menopausal health clinic, but it could be more a standardized way that can be done. Now, that I'm talking about menopausal health clinic. I was not talking about specialist breast cancer clinic. That was the genesis of the talk. Now, the basis of the talk is in the next slide. And thanks to Prajakta, my colleague is sharing the slides. Basis of the talk is called Urvashi. And you all know that as a founder president and a founder secretary, we were very close to each other. And so if something is bothering me, I talk to her. It so happens, and I will share this news, that in 2012, Urvashi got breast cancer. I did also. So we are breast cancer survivors too. Now, based on the talk, I'm writing here that this article had attracted me, requirements of a specialist breast center. And it says breast center, not breast care center. Then I thought that if that has attracted me, let me look through what is the present scenario. What are the challenges ahead for a breast cancer in India? And also current status of breast cancer management in India. These two things I had to go through before I touch upon whether I asked a question as specialist breast cancer centers, does India need it? and my dialogue with Dr. Kanchan Kaur, because Urvashi, when I asked her, are there good specialist breast cancer centers in India? Said, yes, one that I go to. And you would love to meet Dr. Kanchan Kaur. And I'm so glad, Dr. Kanchan, you can say hello. Yeah, she's present here today. And we had a dialogue with her. And it was lovely to her. I'm glad that you are here, Kanchan. And very nice of Shobna. She always welcomes those who are interested in the topic that we are discussing. Next slide shows now that we all know that it has increased. And what is really a thing that I think that we should remember, that in India, 60% of breast cancers are detected at advanced stages. And that's why, what would be the outcome? And that 1 in 3,000 are pregnant and lactating while they do develop breast cancer. The next slide, please. So we all know that both worldwide and in India, you have a pie in this universe of cancers where breast is almost 13.5 ahead of the oral cancer, cervical cancer, lung cancer, and colorectal in India. And in globally, it is 25%, almost 1/4 of the entire universe. And in 2016, 118,000 were the incidence, and the prevalence was 526,000. But by 2020, this had increased to 179,000. So in 1990s, when breast cancer was 4th in the list of all cancers, now it is 1st in the list. And so this article itself was also quite a helpful article with breast cancer in India, present scenario, and the challenges ahead. Next slide, please. So somebody who has not identified this identity, but this graph I got, that 25 years back and presently is shown in red, and 25 years back is in blue. And you can see that between 30 to 40 age group, the breast cancer has increased tremendously in this young age group. So early age at onset, late stage of disease presentation, Indian women have more debt and fragmented treatment. So urban centers, most of breast cancer detected in the age group were 40 to 49 years. Rural areas, highest incidence was between 65 to 69, and urban presented at mean age of 45 years. In a study from North India, 26% of patients were younger than 35 years. That was shocking. Yeah, next. So in India, there is a trend of increasing incidence of young breast cancer. Early detection of cancer for effective breast cancer management and of primary tumors, as well as distant metastasis and recurrent diseases in lower stages, result in better survival. So one important thing is that early detection, and second important thing is improving awareness. That also helps in earlier diagnosis and the treatment. So then I did discuss with Dr. Kanchan many of the things. We will not have time. The time allotted to me will not really allow me to go into certain details, which I would, in my last 2 slides, I would say what I had talked to Dr. Kanchan. And later on in the question answers, if we have time, we will invite her to speak. Breast self-examination appears to be least expensive method, is likely to reduce mortality only if completely performed and if backed up with appropriate diagnostic follow-up. 2 large RCTs on BSc, one from Shanghai and other from Pittsburgh, have not demonstrated any decrease in breast cancer mortality with the BSc. While CBE by trained female health workers resulted in early detection, significant downstaging of breast cancer. Downstaging does occur and reducing mortality in patients more than 50 years of age. This screening of breast cancer, cost-effective solutions for low and middle income countries. This article comes from Tata Memorial Hospital, Dr. Badwe's group. And the next slide. And I had a dialogue with Dr. Rajendra Badwe once. And I was saying that why you think that you were discouraging mammography. And to him, what I was trying to tell, screening, affordability, our questions, I agree, and the expertise and the machines that are available. But if all those things were available, I would still say that the clinical breast examination cannot be compared with the mammography. And while I was saying that, I do realize that there are two different things. One different thing is that when you talk about community screening, is entirely different than when you are individually having a menopausal health clinic, which is very different. And I still feel that some guidelines for mammography should be also there for Indian women. And I came across today an article, excellent article, I think 2022, in 2 northern states. There has been a study by people from MPH stream, and they have shown that the existing health workers can be utilized for breast health education amongst community and home visits, and then back up with, which Dr. Kanchan always says that yes, awareness comes, but what happens if this is not followed by the rest of the breast cancer care flow? There has to be a definite flow of that, the availability of, let's say, mammography, MRI, and whatever is required. And then she did talk to me, and I got stimulated to read about Dr. Frank Hoffman, who had a concept of tactile medicine for detecting breast tumor cancer by blind women. And so there are possibilities of discovering early by employing in a low cost manner certain screening procedures. Next slide. Next. So global guidelines for breast cancer screening, a systematic review for average risk women, mammographic annual or biennial mammographic screening for those aged 40 to 74 years, specifically those aged 50 to 69 years were regarded as the optimal age group for screening. And for women at high risk, annual, it could be a mammography or an MRI, personal history of precancerous lesions or breast cancer, family history of breast cancer, the known genetic predisposition of breast cancer, the history of mantle or chest radiation therapy in dense breast. So these are two different things when you are at an average risk or you are at a high risk. Next slide, please. Heterogeneous socioeconomic cultural pattern of Indian society. And this article was also very important to me to go through current status of breast cancer management in India 2021, and says that rural life for the first 20 years of age has a protective effect, obvious. Lack of multimodality treatment facility, overcrowded treatment facility, and financial constraints result in a delayed and inadequate treatment. Now, the next slide. Okay, specialty breast cancer centers and its evolution. That European Partnership for Action Against Cancer 2014 recognized variations in breast cancer care services within and between EU countries, European countries. Need for cancer care plans to provide clinical guidelines, professional training, and quality control measures. And in 2017, the European Guide on Quality Improvement, Comprehensive Care Control, Comprehensive Cancer Care Networks, integrating expertise under single governance structure. Next. So specialty breast cancer center is one where diagnosed and treated, provide all the services necessary from genetics and prevention through the treatment of the primary tumor to the care of advanced disease, supportive, palliative care, survivorship, and psychosocial support are all the, and these are very, very important. And the next slide shows that Dr. Kanchan and I had a dialogue. In this dialogue, I was telling her that Urvashi was telling me that you have established, and about more than a decade ago, on her return from London, she established, and with all odds, she overcame that. And beside the specialty based academy, we need much or equal focus. Now she says that she would like to, she has created an excellent center and is very passionate about this. And yet she says that now I want to go to the community. Why? Community awareness abhiyan for early detection, backed by the facilities for screening and diagnostic modalities, linked with the multimodality breast cancer care units, networking, and proactive government initiatives and professional bodies' active role, the professional bodies like ours. Next. Thank you so much. Thanks.
Thank you, madam. It was really a very, very nice deliberation on the need of breast cancer care centers. So we are very thankful for you for such wonderful speech on this. And now I'd like to
Rolly, just 1 minute, Rolly. I just want to make one. Sorry. Yeah. Just one second. I just want to say one word. I've not answered the question. I only left the question to our imagination. And when I say that, Dr. Kanchan, who created Against All Odds, and it is one of the best centers and backed by our founder, secretary of IMS. And she says she wants to quit because there is so much that she says that the advanced centers are treating the advanced stages of breast cancer, while they are not supposed to. That should be not be the kind of a scenario. So thank you so much. Thanks.
Yes, we can.
Very well.
Would Anjana like to say something? She's an oncologist.
Yeah, Dr. Anjana, ma'am, if you'd like to say something.
Just I want to highlight, Madam has very nicely highlighted the importance of breast specialty clinic, and it is a need of our. And I think so. It has to be in a way that each and every person is a gynecologist. I will insist that everybody do examine the breast. Even by doing that, also you will help a lot to a female because they are more comfortable with your gynec, and that will be adding to the problem what we are facing now. Madam has very nicely highlighted all the important points for the breast, the importance of the specialty as a breast. This is my.
Thank you, Anjana, ma'am. And I think this concludes the first session, first topic for the scientific session. So I thank my chairperson, Dr. Pushpa ma'am and Dr. Anjana ma'am, and special thanks to our dynamic speaker, Dr. Rama Vaidya ma'am. So thank you all. And now we will move on to the next session, next topic. So for today's webinar, that is a very.
Meeta is saying something. Meeta, you said something.
Meeta wants to have a word with Kanchan, Dr. Kanchan.
Dr. Kanchan, can
Dr.
you come for a
Kanchan, if
minute?
you're there, can you please answer Dr. Meeta before we go on? We'll do that.
Dr. Kanchan.
Yeah. Shobhana, with your permission, just a 30-second, that's a misinterpretation of my question, Dr. Kanchan. I was talking not at all about mammogram. I was talking about the Gale, but we will discuss it later. You can put it in the chat box because I don't want to stop the flow of conversation. Yeah. So you could put it, because that will take a long time for discussion. So you can put your answer there, because I don't want.
We will, if we have time after the panel, we will have detailed discussions.
Yeah.
I'll try to finish my talk fast so that we can have discussions at the end of the panel. Because my talk is only on MHT, so I'll just rush through it. And so that we can have all these esteemed people talking a lot of things. Yes.
Okay. So we will move on to the next session. That is on HRT and breast cancer. And for this, we have a very, very learned and versatile speaker with us, Dr. A very warm welcome to you, ma'am. I would also like to welcome our chairpersons for this session, Dr. Neela Ori and Dr. Vimal Shah. I welcome you, ma'am. I would like to take the privilege to introduce our chairperson. Dr. Neelam Ori ma'am is MS FICOT, fertility consultant and gynec laparoscopy surgeon, German diploma in ART, certificate in ART South Korea. She is the medical director of New Life Hospital and Advanced Fertility Center Varanasi, chairperson ISAR-UP, secretary UP-AIGE 2021 and 22. She is the secretary of Varanasi Menopause Society and past president of WAP. She has various publications in national journals and various chapters written for books. Her special awards and recognition are she has organized many national conferences on infertility, fetal medicine, life gynae, endoscopy workshop, hands-on IUI, and ultrasound workshop. She is also the recipient of Shani Kasi and Kashi Dutt Award. I welcome Neelam ma'am.
Thank you. Thank you very much. Good evening,
And
everyone.
now I would like to introduce our next chairperson, Dr. Vimal Shah. Dr. Vimal Shah is a consultant, gynecologist, and laparoscopic surgeon. She is MD of Gynae Gold Medalist, MS University, Diploma, Gynec Endoscopy, Germany, CINT, FITOD. She is the organizing chairperson, IMS Con 2022, National Chairperson, IMS Club 35 Plus, Public Awareness Committee 2022-24. She is the past president of GOS 2016-17, past president, Menopause Society, Vadodara, 2021-22, topside representative from GOS. She has been awarded with Inspiring Gynecologist of West India by Economic Times. Has also awarded as a Wonder Woman of Vadodara by Radio City 91.1 FM, appreciated by CM Shri Rupani Ji for Women Health Awareness Activities. She is the Pride of Vadodara Healthcare Icons Award by Times of India. And I think she has also been awarded Miss Estate and Grand Pageant winner, Mrs. Rajasthan 2020 and 21. I welcome you, ma'am. And I would now like to. Yeah. Good evening, ma'am. I would.
Okay. It's really a
great privilege. Okay. It is really a great privilege for me to introduce the president of IMS, Dr. Shobna Mohandas. And she is, apart from being president of Indian Menopause Society, she is chairperson of Women Doctors being IMS Thrissur. And
I think you don't have to read all of it, Dr. Neelam.
Okay, so she is really taking our Indian Menopause Society to a greater heights. And I'm really very happy to join this webinar on a very special subject for women. They first come to us and then they go to anybody else, any other specialty. So Dr. Shobna, we are really eager to have you.
Thank you, Dr. Neelam. She had conducted the annual IMSCON and the great difficulties, but she stood on stoically and made a success of it. And I think we should all emulate Dr. Neelam Mori for that emotional strength that she has got. We really salute you for that, Dr. Neelam.
Thank you, madam.
So now with that, I will just share the screen and talk. I will make my talk brief so that after the panel is over, we can have some discussion with the stalwart sitting here. And yes, can you see my screen?
Yes, madam. Yes.
Yeah. I bring you greetings from Thrissur and my hospital. And the basic problem, in MHT is estrogen causing breast cancer, is progesterone causing breast cancer, is both causing breast cancer, and so should we take hormone therapy? Everybody's so scared. Progesterone is there in the lobular system and estrogen is there in the duct system, and most of the cancers are there in the lobular system. That itself tells you maybe because progesterone increases the proliferation, the autocrine and the endocrine, and it alters the PR signaling pathways. And patient tumor samples basically and clinical studies all indicate that progesterone is a risk factor for breast cancer and it contributes to cell proliferation. This is what they all tell us because it's common sense. Progesterone controls proliferation. It drives the expansion of stem cells, and the breast epithelium mostly proliferates in the latter half. That is where the progesterone is acting. And during the mid to late pregnancy, also the progesterone has another role to suppress the secretory activation. So all there, the breast is all under control of progesterone. That's what we all think. But what about estrogen? Through RNA, it always increases cell proliferation, enhancement of genetic mutation. So if there is too much of estrogen, there can be insufficient time for DNA repair. You can't go on producing before the old ones are repaired. We always say till the old salt is over, old oil is over, don't pour new oil. So you have to wait for the DNA to be repaired. If it goes on proliferating too much because of estrogen, then you will have an enhanced rate of cell growth and stimulates genes with growth factor production. All these things are there with estrogen also. And estrogen-induced cell proliferation and lack of DNA repair. Before it is repaired, more proliferation is happening. So that can lead to breast cancer. So you can't say only progesterone because progesterone is more important. Obesity, we all know that obese people have more increased risk of breast cancer. And what do obese people have more? They have more estrogen. So that way, if you go to see, estrogen should be causing cancer. Another problem was with this WHA study. When WHA study, they had to stop it and all that. We know that because of stroke, breast cancer, infarction and all that, they had to stop the study. But that is the only one part of WHI that most people know. But we all should know there was an estrogen-only arm where they claim to have studied 10,000 hysterectomized women, no estrogen. And they were given estrogen because they don't have to worry about progesterone stimulating the endometrium, and there was decreased risk of breast cancer. So all of us as menopause practitioners, we go and say progesterone, estrogen is not important. So, but there was something like, why is it true? Why this WHI, the estrogen breast cancer seem to be low? This gentleman called Jordan, what he says, when the cells are deprived of estrogen for 5 years, this WHI was done in the older women mostly. So they were all 60s and things like that. That's why they all got stroke. So that was there. So they were not the young ones. They were the ones who had been off estrogen for practically 5 years. So when these people are given estrogen, the cells will die not grow. Whereas if you give estrogen to the younger ones, they will grow. So after the death, when you give estrogen, the cells will go and die more. Thus, 5 years post-menopause, estrogen therapy will actually kill cancer cells. And the same thing doesn't hold good even if estrogen therapy is started immediate post-menopause. So a little confusing. That is why the WHO study is showing that all the breast cancers are decreasing. That really doesn't mean that estrogen is an absolute no-no. For I mean, it's absolutely like, you can't absolve estrogen totally of the guilt of increasing breast cancer. So again, probably but that doesn't mean whether you give estrogen, whether you give progesterone, whatever you give, what is the risk for cancer, for God's sake, even if you use all of it. So the risk for cancer at the ages of 50 to 69 years after giving 5 years of MHT is increased only 1 in every 50 women. This is a 2019 study that they have shown. That is not, the incidence is increased. Okay, that means already it is there, that already incidence, it's not new breast cancer, the incidence is only increased. And so what does it mean? There are 2 studies. One study, they picked up all the healthy women who died of, heart attack or whatever, and they took all the cadavers, and they found that undiagnosed breast cancers were there in 7% of women who died of anything other than breast cancer. So detection range was only 1.4 centimeters in 40 years and 0.8 in 70 years. So that is the detection rate. And so finally you have to detect it in the cadaver. So another study, they removed all the studies, 13 studies from 1948 to 2010. And they are talking of 2,363 autopsies. And they had 99 cases out of 2,000 people. Imagine, out of 2,000, almost 100 are having incidental cancer. So when that increases, you can't say that it's caused cancer, it's only an increase in cancer. So what is, finally, we are not good statisticians. What are the pundits saying? 10 year, 20 years and 30 year of risk of developing cancer is only 0.45 in 30-year-olds, 1.47 in 40-year-old, 2.31 in 50-year-olds, and little more 3.45 in 60-year-old. So it's not really high. Why are you so scared? You can die of a heart attack much more than that. And let's say, what are the other risks? Just not estrogen. Personal history of cancer, gender, family history, breast tissue density, and age. As you grow older, you can have more incidence of cancer of anything, okay, breast, any other organ. So it's the age by itself which is increasing the incidence of cancer, what I showed you in the previous slide, not just the fact that they're taking estrogen. So the relative risk of breast cancer in current EPRT versus non-users is, when there is estrogen progesterone therapy, it is 2.08, non-users is 2.02. So it's just a small increase. Even this 2.8 is slightly only increased with levonorgestrel, norethistron, or medroxyprogesterone. So basically, when you see 2 and 1.96, where is that much of increase? This point here, there. That's all that is there. So when WHO reported that the breast cancer among women using combined estrogen progesterone was increased, actually one arm they had 30 breast cancers where people were taking of both these drugs, and the other arm they had 38 out of 10,000. Okay, that means what? There is only 8 additional breast cancers per 10,000 women. That is not very high. 8 in 10,000 is what? Nothing. So the breast cancer risk attributable to CEA, MPA after 5 years of use is only 0.64% in 2022. Forget the older studies. Even in 2022, the actual cancer risk attributable is only 0.64%. And that also is more with synthetic progesterones. And when you think of micronized progesterone, The mammographic density may either increase or remain unchanged. The proliferation induction was less pronounced compared to conventional MHT. Breast cancer risk was not affected for up to 5 years, not at all affected. Even that point affection is not there, not at all affected for up to 5 years of treatment. And estrogens combined with micronized progesterone or dihydrogesterone were associated with a slight increase at the end of 6 years. At 5 years, absolutely no change. After maybe 1 more year, little increase. But as it is, there is only 0.64% rise. That 0.64 will come down to 0 with 5 years. For that, whether you want to, that point little bit difference out of 10,000, you want to pay more money, that is not for breast cancer, but there are other advantages of the other progesterones also. But just for breast cancer, when you think the advantage of using the costly progesterones is not that higher, but they have got many, many other things. Of course, this is not the time to speak about all that. Okay, now what are the other progesterones used? People are using LNG IUDs. So 17,000 people in Finland. I don't know how they could get so many people in Finland where there is hardly any population. We have in India, we can't collect so many cases. And then they found that the incidence of breast cancer was the same. That means no change, so no increase with LNG IUD. But again, another fellow came and said, no, there is a little increase. And why that other fellow is wrong? Because the random sample of Finnish women aged 15 to 64, they are more often married, it seems. Means they have 3-4 married. They have a higher socioeconomic position. They're less often overweight. They are all, going to the gym, and they were less smoking less, took more exercise, consumed alcohol slightly more. So therefore, anyway, the cancer risk would have been less. So you can't believe them. So whatever it is, LNG IUD also is a good option. So finally, we have to say that women have 100 times more risk of breast cancer because of estrogen, plasma estradiol level, age at menopause, first live birth, early menarche. All these things affect cancer. In postmenopausal women aged 50 to 59 years, combined estrogen and progesterone HRT over 5 years, only 3 additional cases per 1,000 women. And the risk is not significantly increased over 3 years of use. And because HRT only enhances the tumor that is already there, when you give HRT, it will make the breast cancer more evident faster, and that therefore you will be diagnosing it at a much earlier stage. Please. So this it will be less virulent, because you diagnose it faster. So that is much. In fact, if you have a small breast cancer and you take HRT, it will be good for you because you'll be diagnosed earlier. Now, if you are receptor positive, the DNA damages are much more. That's why you cannot give estrogen in receptor positive patients. So another thing is, if you're receptor positive, tamoxifen and letrozole will give drugs, and it will improve only estrogen receptor positive tumors. Now, can estrogen receptor negative patients take HRT? There was a meta-analysis. They say that there was no difference in recurrence, but when you think of all the DNA damage that can happen in estrogen positive, receptor positive people, it is a bit scary to believe this one study. Tibolone does not increase mammographic density. So that's the best part. You can at least do a mammogram and find out if there is a possible. It is effective in alleviating hot flashes, and especially when you have chemotherapy. Nowadays, breast cancer, they give immunotherapy. They don't even give those big chemotherapies. They give a lot of immunotherapy, and then they remove just a small little portion of the breast. They don't remove all of the breast, and all the time they have to be worried about using those mastectomy pads, and they're not comfortable with the mastectomy pads. They go on searching Amazon for that right mastectomy pad. All that is gone now. They just give immunotherapy, take out a little bit of the breast, and you still have your breast there. You don't need mastectomy pads. So Tibolone could be a treatment option for women persistently seeking help in the older days where chemotherapy was the only way of treatment, because those patients really get real bad hot flashes, And then those people are going to come to you now. Maybe this non-chemotherapy people will go to you, or the juniors who are now just passing out. So long-term intervention on fractures with Tebelon was there. Where for fractures, they were studying Tebelon. But when they found that in that particular study, the breast cancer incidence was reduced with Tebelon. So that is also to be thought of. There was a Livial study, non-inferiority of Tebelon to placebo regarding the risk of recurrence in breast cancer. So Tebelon is a good option. And Mita's consensus in 2008 says EPT more than 4 years is associated with an increased risk of detection of CA breast. EPT does not appear to initiate malignant transformation, but to potentiate it. So it will be diagnosed faster. Cancer breast detected during HRT use usually is less aggressive, more favorable prognosis. And this is a repetition. Up to 7 years, it does not significantly increase breast cancer risk. And young people who are starting combined HRT for the first time should be advised that breast cancer risk do not appear to increase in the first 7 years of use. Sometimes they get addicted to the HRT, where especially surgical menopause and all, when they are using it, they just sort of get addicted. I can't stop it, doctor, I have to take it. And so up to 7 years, they can continuously take it. There is no problem. We can advise our relatives, aunts, whoever asking us for that. And then, but the data on HRT in women with a family history of breast cancer is inconclusive. An individual risk has to be assessed. And most of our patients will talk of something, and survivors, I told you chemotherapy has got very big, lot of hot flashes in those patients. Consider in some women whose quality of life is impaired by the estrogen deficiency. They're really badly off. Then maybe you can give a little bit of HRT. Risk of recurrence must be explained, so they must be continuously monitored. You can give a fair trial with alternative therapies. You don't jump onto chemotherapy, ERT first. First try with your gabapentin, everything, your all other trials. And if nothing works and she's still suffering from hot flashes, maybe a short-term therapy can be tried. Lowest effective dose can be given for a shortest duration of time. Now, about the use of local estrogens, you have patients with hysterectomy. I had a recent patient who was undergone VH, and she had not even told me she's a breast cancer survivor. And I said, madam, you can try using little local estrogen for, after the surgery to just keep your this thing supple. And she comes and tells me, doctor, I am a estrogen receptor positive breast cancer survivor after 10 years. And she doesn't even tell me before. But then for such patients, you have a lot of patients with genital atrophy where you do think that 1/10 of the not even 1/10, 1/100 of that normal oral drug that you have in the vaginal one, that is not going to cause any harm. The problem is such a small thing has not been researched. No researcher has found it worth researching. Therefore, we don't have data. And therefore, we do not know really whether that can increase it. That's all. Just because we don't have data. Somebody can take up that as this thing. That's good. So, the relationship between use of HRT and breast cancer can be known only after 4 years of use. Do not deny short-term low-dose HRT to symptomatic women. Estrogen therapy in hysterectomized women does not increase the risk. Tebelon may be a better choice because even you can do the mammogram better. No, the mammogram won't be affected. Prudent to withhold HRT in breast cancer survivors. And thank you for that patient hearing. I finished, I hope, much before time, so that we can have better discussions after the end of the panel. But thank you, Binal. Even if that slight change of progesterone is there, even with the normal progesterone also, the risk is not really high. So all that hype about using higher progesterone, we will discuss after the panel discussion. We will have a proper fight with each other to decide what is right and what is wrong. Okay.
But very prudent talk, Dr. Shobna. It is really full of evidence-based facts. And we all gynecologists are really scared of giving this a charity. But you very clearly said that this actually does not increase the risk. It just accelerates the growth. And so it is caught up early.
Thank you, madam.
Thank you, Dr. Shobna. Yeah.
Thank you, Binala.
No, she is not there, I think.
Carry on with Anju's.
Yeah, we'll start with the panel discussion, Dr. Rul.
Thank you. Thank you, Rolly. Let's not waste time in introductions. And start with the panel. Can I share my screen, please?
Anju, let the panelists be introduced, even if it is only one line.
Okay. No problem. So you can. Dr. Ragini must have joined. She said she'll join by 7.
He is joined.
Yeah, you're there. Okay, great. Yes, we can see.
Anju madam, please introduce our panelist. Anju madam.
Yeah, so it's my privilege to introduce none other than Dr. Ragini Agarwal. She doesn't require any introduction. We all know that she has been the brain behind Haryana OBGYN Association, and who is working so actively. She has been president-elect North India, and she has been vice president of FOXY. She has been working in the aesthetic committee of Indian Menopause Society, and she's done lot of work. So welcome, Dr. Ragini. It's our pride to have you at this panel. Next, please. Can I have the next CV, please? Yeah. Amrita is another active person from Gorakhpur, Dr. Amrita. And we all know that how actively she works in the Indian Menopause Society. Welcome, Dr. Amrita. Next, please. Dr. Leena Nair is past secretary of Bhagalpur OBGYN Society and is treasurer of, again, Bhagalpur Society. She has been very active member of Bhagalpur. Welcome, Dr. Leena. Next, please, can you show the next CV? Dr. Shubha Sethia is president of Jaipur Menopause Society, and she's a very active person, and she's been working very actively. She was also vice president of Jaipur Obstetric Society and secretary and treasurer of JOGS and JMS. Welcome, Dr. Shubha. Next, please.
Thank you, ma'am.
Next CV, please. Yeah, Dr. Anupma Sinha is a senior associate professor, and she is a gold medalist. Welcome, and she's secretary of BOGS. Welcome, Dr. Anupma. Next, please. Can I have the next CV, please? Dr. Basundra Lal is consultant gynecologist and she is working in Lal Hospital. She is past secretary of Bhagalpur OPGY Society, another active member from Bhagalpur. I believe Dr. Pratibha has made everybody very active. Welcome to all Bhagalpur people. Welcome, Dr. Basundra. So can I think I have introduced all of them. Yeah, is there any CV left? So can I share my screen now?
Yes, you
Yeah,
can.
thank you. Yes. Just give me a second. So today we are going to talk. Sorry, one second. Sorry. So we are going to discuss the breast lumps today, and it is one of the very important topics. We have been listening to the Star Wars in this area, and the most important part is the breast cancers can be diagnosed early, and when they are diagnosed early, the chances of 5-year survival are very good. So we have learned panel of panelists with us, Dr. Ragini, Dr. Amrita, Dr. Leena, Dr. Shubha, Dr. Anupa and Basundra. So welcome you all. And we all know that breast is a symbol of womanhood and ultimate fertility. So as a result, both disease and surgery of breast evokes a fear of mutation and loss of femininity. So it's the femininity which is associated with breast, we all know that. And this is a picture of Angelina Jolie, but she still went away with her breast for the reasons we'll come forward and listen to it. So this case is to Dr. Ragini Agarwal. A 36-year-old female came with the complaint of paleness lump in right breast since last 3 months. On examination, the lump was well-rounded, well-circumscribed, 6 into 5 centimeter, firm, non-tender, freely mobile, and not adherent to skin and underlying structures. So, Dr. Ragini, what is the probable diagnosis? Does it need further investigation? And what is the treatment of this patient? Does it differ according to the age of the patient or the size of the lump? Please give us your So very well said. But what I wanted to highlight here is that though the fibroadenomas are very common, but they are seen from teenage to 40 years of age. And we must, look into these patients. And there are rare in adults, but they are not absent. And then seen in plus 60, they are not seen. So this is a picture of a fibroadenoma, as Dr. Ragini has suggested. This is a clear-cut lump on ultrasound. very well visualized and very well we can, diagnose it. And these are the guidelines. It is said that fibroadenoma is a stromal epithelial proliferation rising for terminal duct of a lobular unit. It is basically a benign tumor, but transformation is rare. But we need to follow up with reassurance if it is educated. There are some cases where there giant fibroadenoma or complex fibroadenoma are there, and if they are persisting even after the age of 35 years, and there is unnecessary for excision. So there are different types of fibroadenoma which we must differentiate because it is very important for us. There are small fibroadenomas have pseudocapsules with bright white clefts and fibrous connective tissues. Juvenile giant fibroadenomas are pseudocapsule with pale brownish gray clefts and foliaceous with relaxed connective tissues. And there is abundant proliferation of ducts and acini. And of course, there is benign phyloid tumors, which are again have a cell delineated brownish gray clefts, and they need to be differentiated from malignant phylloids, which are very having atypia and scarce mitosis and which are dilated ducts. So we must differentiate between the phyloid tumors and fibroadenoma, even if they are, non-cancerous. And the less than 5 centimeter, we need to follow up, do a biopsy, and if it is more than 5 centimeter, excision is advisable. If there are multiple small fibroadenomas, we need reassurance and 6-monthly follow-up with ultrasound. And if the fibroadenomas are giant or complex, hovering epithelial calcification, apocrine metaplasia, sclerosing adenosis, or fibroadenoma persisting after the age of 35 and a family of breast cancer, we have to excise them. So this next case is to Dr. Amrita. Dr. Amrita, this is a lady who is 8 years old. She came with the complaint of pain in both the breasts. There are lumps in the breast which are typically increased before menses. On examination, both breasts are tender. No well-defined lumps, rice grain nodularity, slightly thickening at the upper and the outer quadrant. What is the diagnosis? Number one, does it need further investigations? And number three, what are the treatment for this patient? And do you think that there is any, what kind of management it is required? Sorry. You have covered what I wanted you to, that there are cystic changes, but there can be metaplasia along with adenosis and fibrosis. So we need to diagnose it, especially in this case, we know that it is perimenopausal, syndrome, and this is because of the imbalance between estrogen and progesterone during the period, and it worsens with caffeine premenstrually and premenstrually. Investigations are ultrasound as per the guidelines. The risk of malignant transversion is still 1.5 to 3%, which is quite high as noted. So we have to follow these patients. And for management, we have to tell them to cut down on the intake intake of caffeine in the form of tea, coffee, soda, and energy drinks. They have to decrease their added sugar and fats. They have to increase the fiber intake up to 30 grams. They have to eat more fruits, vegetables, and whole grains. Hot fermentation, breast support, NSAIDs if required, and decrease estrogen intake, OCPs, vitamin E, primrose oil, GLA and fish oil are helpful. We have seen all in our day-to-day practice. But sometimes these patients may require SERMs or oxylifen if they don't respond to our treatment, and danazol or tamoxifen are only used as a last resort when the pain is not relieved with all the other treatments. So, Dr. Leena, why do you think we should screen for breast cancer, and how common it is in India? Of course, Dr. Rama had covered it very well, but just in few lines, if you could tell us.
It is very important to know that breast cancer has replaced cancer cervix as the commonest tumor in female in India. So there is a very important need for screening for breast cancer because it is now so common, and most of the cases are diagnosed late when the treatment and survival rate both become affected because of late diagnosis. So the earlier we screen for breast cancer, we will have better outcome as far as treatment and survival rates are concerned. So it is very important to screen for breast cancer.
Yeah, very well said. And Dr. Rama has already highlighted that breast cancers are found during screening and examination are more likely to be small and still confined to the early stages. And the size of breast cancer, how far it is spread, is very important factor for the survival. So we have to examine, and we as gynecologists are at the forefront, and every patient who comes to us, we must do their breast examination so that we can diagnose at the first stage, and they are more comfortable with us also. We all know that. And we all know that the cases of breast cancer are increasing day by day in our country, and they are also being more common at a younger age. And I know of so many of my residents have got this problem. So the younger age, they are becoming more common, is what is the fear we have. So that is why we are talking of the screening, especially our own involvement. And I feel breast is an organ for gynecologists, not the surgeons. So we must look into it as the as the first person with the patient who comes in contact. So the other question is again to you: what are the components of breast cancer screening? What are the risk factors of breast cancer, and can we prevent it? Leena, Dr. Leena, are you there?
Yes, ma'am.
Yeah.
The components of breast cancer screening are manifold. Of course, the gold standard being mammography, but in a population like ours in India, it is not possible to screen women with mammography. So the best thing we can do is to make people aware with self-breast examination. Though data suggests that this has not downstaged the incidence of breast cancer. The other one is the clinical breast examination. You can train health workers and they can come to the doctors, and if we screen them, we will be able to detect them at an earlier stage. Now, as far as India is concerned, we do not advocate an universal screening for breast cancer. We do risk screening, and we subject those women who are at increased risk for breast cancer to undergo proper screening at a particular interval. Now, as far as the risks are concerned, the reproductive history is very important. Women who have early menarche, that is less than 13 years, they or those who have late menopause, which exposes them to a long duration of estrogen and progesterone stimulation, and those who have late childbearing and less of parity, like nulliparous, uniparous women, they are more prone to develop breast cancer. Those who have not breastfed their babies for a long period, they are more prone to breast cancer. Then you have family history, particularly those, if your first degree relative, mother, sister, or daughter, if they are having breast cancer, it increases your risk of breast cancer to a great extent. Then certain genetic risk factors like those who have BRCA1 and 2 gene mutations, those who are overexpress the HER1 and 2 gene proteins, they are at increased risk of breast cancer. Then we also have some modifiable risk factors like obesity, less of physical activity, all these, those who take alcohol, and particularly those who are taking hormone replacement therapy after menopause, or those who have used oral contraceptive pills for a long period, they are at increased risk of breast cancer. So these women need to be subjected to screening at regular intervals to detect breast cancer at the earliest. As far as prevention is concerned, the earlier, those who have a family history and other factors, they need to be, we can subject them to either chemotherapy, chemo prevention like use of tamoxifen, or those who have like HER1 and 2 protein, if they are overexpressed in these females, then we can give them the hormonal treatments like trastuzumab and like other things, and these can prevent to a great extent the development. They can, some of them who have BRCA1 and 2 genes, they can undergo mastectomy to prevent their chances of becoming having breast cancer. Madam? Hello, madam.
Anju, have you lost your connection?
Very well said.
It's a poor connection. The voice is coming very.
We're not able to hear you, madam.
Voice is low.
Now
Am
we
I
are
audible
little bit.
now?
Now, yes.
Yes, yes.
Yeah. Yeah. So, yeah. So I'm better now.
The slide is not moving.
Am I better now?
Yeah. I can't hear you.
Now better?
Yeah.
Is it better now?
Yeah.
Yes, yes. I can hear you now, ma'am.
Hello. Acha, एक
Yes.
second. Hello.
I think Anju has lost her connection. So the panelists, who have been given the questions before, can you please elaborate on the answers, whatever have been given to you, one by one? Yes. Hmm. Yeah. Hmm.
No, no, I'm audible.
Yes,
Yeah,
yes.
now you are audible.
Yes, yes. You have to share your screen, madam, again.
Yes, I'm doing that.
No, we had our surgeon who was operated on around 10,000 cases of breast cancer. His daughter-in-law got breast cancer during pregnancy. And you can't imagine a 28-year-old girl getting cancer. And it was a very virulent cancer. But I think she's surviving even now. But it's not unheard of. So when they're giving these cases for discussion, it's
Are my
really
slides
relevant.
seen?
No, no, madam.
Not yet.
Are my slides seen?
No.
No, we can't. You have to share screen in your slide first itself and then start sharing. So this case is, it's not unheard of to have even lactating women, when you get a breast lump, you think it is not cancer because you never think it can happen. But general surgeon who has operated on so many cancers, his daughter-in-law gets that. So it's really sad. Now, what do you think, Amrita?
Are my slides seen?
No,
madam.
Yeah, Amrita, start. Okay, Amrita, your take on that.
Are my slides seen now?
It's coming now, slowly. Let
Hello?
Amrita continue meanwhile.
Dr. Shobha,
What will you do, Amrita, finally? Will you advise biopsy? Will you advise mammography? What will you do for her? Only a way out. How do you differentiate it from collection of milk inside the
Yes, ma'am. Yes,
Yes.
ma'am, we can see your slides now.
Yeah.
How do you differentiate it, Amrita? Yeah. I know it's impossible to have retracted nipple and red things and pudia orange and everything in a mastitis. I'm just asking.
Course of antibiotics. We can give a course of antibiotics.
Anyway, like Dr. Leena said, one course of antibiotic we'll always try anyway, whatever we say, because we always think it is mastitis. Yeah. Okay. So everybody does it once at least. That message has to be given out that you are not wrong in giving one course of antibiotic and anti-inflammatory, however bad the case may be, and however we see scary cases in our life. 5 days trial is not going to harm anybody. Yes, Anju, take over now.
Yeah. So
Amrita's case is done with. Now you take over the next person.
Yeah. So breastfeeding, we have already discussed. Self-breast examination already discussed. But what I want to stress here is that it has to be started at least 20 years, at the age of 20 years, and continuously in the postmenstrual period. So it is very important to do self-breast examination at an earlier age. And if you feel any kind of change in the shape, size, and even looks, we must, examine and go to the doctor for the examination, and so that they can feel your breast. And a clinical breast examination must be started by the age of 30. And the signs or symptoms, we all know that these are the signs and symptoms: the abnormal shape, swelling, or maybe redness or a discharge, which need to be, most common being lump and thickening in the breast. along with which can be painless. There could be discharge, there could be change in the size and shape, and there could be change in the color and appearance of areola, or there is redness of pitting in skin and the breast. So the guidelines are that we must do a monthly examination for 20 plus, and every 3 years it has to be done by doctor. At 40, mammography annually, and high risk cases mammography plus MRI if required at the age of 30 years plus. So this is the question to Dr. Shubha Setia. What are the guidelines for breast imaging? Dr. Shubha, are you there?
Yeah, I'm here.
Yeah.
So breast imaging can be used for two purposes, as we have already said in screening. First is screening, imaging for screening. And as you have said, after 40 years of age, in India, we start screening for breast cancer in a normal risk patient. And if in case of high risk cases, screening is done after 25 to 30 years of age. And in these patients, MRI is also done. But apart from this, breast imaging is an important part of screening in whenever there is a breast lump or breast symptoms are there. So whenever we are dealing with these patients, we have to keep the age of the patient as well as in mind before we start deciding what is the screening modality that we are going to use. So in women who are a bit less than 30 years of age, because they have a very dense breast, mammography will not be very informative, and the sensitivity of mammography in these patients is only 33%. So ultrasound is a better diagnostic method in these women. And between 30 to 50 years of age, we can use mammography as a imaging modality. But if the breast is dense or we are not able to reach to a conclusion, a sonomammogram would be a better alternative. And after 50 years of age, it is better to do it is better to go for mammography is the first line screening. But again here, if there is any confusion, sono can be used as a measure. Now, as far as the type of mammography is concerned, usually during screening, a full field digital mammography would be better, and the 3D ultrasound, that is tomosynthesis, has been shown to have better effects. As far as then we can have the contrast enhanced mammographies may also be done. Then apart from this, in case of ultrasound, we can use, if available, and if the competence is there, elastography is a very useful method, because what we do in elastography is we see the ability of the tissues to have an elastic recoil, and the malignant tissues will not recoil on any pressure, whereas non-malignant tissues, and therefore this elastography, if added to our investigations, will give rise to increase in sensitivity and specificity of the investigations. And one thing that we have to remember is that whenever we are using imaging modalities, our reports might change if biopsy has been done earlier. So whenever we are examining a patient, keep in mind that first finish all the modalities of imaging that you want to take on this patient. And once all modalities have been finished, only then go for biopsy, so that there is no, on if suppose the biopsy has not been done, better do the imaging after 14 days of the biopsy. Apart from that, MRI also has a role in the high-risk cases. So whenever there is high risk of patients with high risk, MRI may be more informative as compared to mammography. But in these cases also, we must remember that MRI may miss that ductal carcinoma in situ, as well as lesions that are less than 3 mm in diameter. As far as PET scan is concerned, there is no role of PET scan. It is only for the cases with breast cancer, where we want to do a staging, that we would use this. Otherwise, as far as screening and diagnosis is concerned, we don't use PET scan. And apart from that, remember that whenever we are doing imaging, we must not forget that ultrasound of the axillary region is also very important whenever we see a lump, so that we rule out any secondaries in the axillary area.
And we must always report. The reporting should also be according to the BIRATS criteria. So these are the things that we have to remember while we are doing a mammography.
Very well said.
In our patients.
Very well said. USG below the age of 30, USG plus mammography 30 to 50, more than 50 mammogram, USG only if indicated, and MRI if the results are unequivocal in cases of mammograph and ultrasound finding. These are the general protocols. We all know about ultrasound. She has just discussed. A mammography is a machine which an X-ray plates are pressed, breast is pressed between the X-ray plates, and we can easily look into the calcification on the breast tissue, which is very, very helpful because the cancer cells have a tendency to be calcified areas. So this is a case to Dr. Anupma, a 44-year lady who came for a screening mammogram with a strong family history of a cancer in the mother as well as sister. This is her mammograph picture. Now, what are the significance of a BIRATS category? Dr. Anupma, are you there? Dr. Anupma?
I think she's unable to join actually. Dr. Anupma, should we join? No.
Anybody can, Dr. Ragini can take this. Dr. Ragini, can you take this, please?
No, she left because she had an emergency.
Anybody can take. Leena?
Yes.
Yeah, Amrita, you can take this.
One.
Hello? Achha. Hello?
Dr.
Can you unmute Dr. Anupma Sinha? Hello? She has joined. I think somebody has muted her.
Anupma, are you there? She can unmute herself. Anupma, you can unmute yourself. Debulina? Debulina?
Yes, ma'am. I'm sending a request, but she's not taking my request also.
It's okay. Let Dr. Amrita continue. Amrita, you continue, please. Let's not waste time. Dr. Amrita, you continue, please.
You finish category 3. You please continue with the remaining.
We can see in these pictures that this is a normal breast in category 1. Category 2, benign finding. Category 3, we can needs a follow-up. We can see some calcification being there. And category 4, we can is a suspicious lesion. We can see easily there are indistinct margins and they're pleomorphic.
Anju, we are running out of time. Can you just speed up, please? She's already explained everything now.
So next question is to Dr. Leena. What are the limitations of breast ultrasound and mammography? Because it is very important for us to understand what are the limitations.
The limitations of breast ultrasound, first of all, is that ultrasound may not pick up some of the lesions, like it may not pick up the microcalcifications as well as we can pick it up in mammography. In dense breast, though it is a better modality than but when the breasts are very dense, then also we can have a problem with breast ultrasound. At that time, MRI is a better option. As far as mammography is concerned, again, dense breast is one of the limitations. and we cannot access the axilla and other parts with the mammogram. These are the
Very well said.
limitations
What
of-
is very important for ultrasound is that it is basically a real-time examination. So the expertise and good equipment is very essential. If you do in a equipment which is not good quality, we may miss the thing. So we have to have it's a basically person-based and machine-based thing. So this is one of the very big disadvantage of ultrasound, and we can see that this is the dense breast. We can, but limitation of mammography, it is not 100% accurate. It is false negative. Even if there are breast cancer, it can be false negative. False positive results are also there when the mammograph may show normal breast, and also overall screening mammogram. It is found that 1/5 of the breast cancer can be missed in these cases. So women with dense breasts have most false negative limitations. So we must combine them with either ultrasound, and if still we can't, find anything, we must resort to MRI. It's only when sono and mammo are inconclusive, and in young women with dense breasts or a family history of breast cancer, we must talk of a breast MRI. So this is guidelines which are again talking of the same thing. In a short, I have put in a table where clinician should follow these guidelines. They're available on the net. And this question is to Dr. Basundhara Lal, a 32-year nulliparous woman, noticed a lump in the left breast 1 month ago, and it was painless. On examination, there was a vague lump 2 into 2 centimeter, and she basically had irregular outline, tender, hard consistency without any nipple discharge. Axillary right breast was normal. And what is the probable diagnosis? How will you manage this case?
My case is 32-year-old having lump in left breast 1 month ago only, which is painless, irregular outline, vague, size 2 into 2 centimeter, non-tender, hard in consistency. All goes in favor of CA breast, and most probably this is a case of early breast carcinoma. Further, we will take a history having of her first degree relatives with breast CA or not, because it double or triples the risk of breast CA, age at menarche, or history of a high risk lesion found by biopsy, or any radiation therapy on the chest, or non-genetic mutation BRCA1 or BRCA2. Then advice for mammography and true-cut biopsy to confirm the diagnosis.
Let us be sure, to the point. That is why I showed this point. Clinical examination, cyto. This is a triple assessment algorithm. Vague, irregular, malignancy, painless. It could be, malignancy, because the lumps margin, and investigation we all know, and MRI only if it is inconclusive. So biopsy, as already Dr. Ragni said, true-cut biopsy, FNS is not done, and true-cut biopsy should be taken, especially the core one, and lumpectomy in some cases is required, and USG guidance is must. USG guidance is must for all FNSs and core biopsy, even if very large masses are there. So stereotactic biopsy should be taken. Then general protocol is that we must have surgery as option. It could be a radical surgery or a conservative surgery. Always
conservative surgery is the goal, madam. Nowadays, conservative surgery preferred, and in this case, taking 1 centimeter margin on surgical excision with taking 1 centimeter margin, madam.
And the tissue,
and further we can look for whether the tissue is hormone sensitive or not, or human epidermal growth factor positive or not. So, because with local excision, chances of recurrence is very high. So that we can take fast if recurrence occur.
So we send it for histopathology, ER/PR receptors and HERS, and also post-operative chemotherapy and hormone therapy has to be combined. In case it is HER positive, we have to give her Herceptin immunoglobulin so that she can be easily controlled. So Dr.
Yeah.
Ragini, what is oncoplasty? Dr. Ragini is there, not there. Anybody can take this. Is she there?
No, she's not there.
So anybody can take this.
I just have to read it out, no?
Yeah.
Oncoplasty is a conservative surgery for breast cancer, madam. Earlier, we used to do radical mastectomy or modified radical mastectomy, but now with oncoplasty and advancement in the care and post-operative follow-up of the breast cancer patients, now we can remove a small part of the tumor with a 1 centimeter or a 2 centimeter margin. And then we can offer a breast reconstructive surgery to these people and follow them up with advanced receptor positivity. If they are hormone receptor positive, we can go in for hormone therapy later on with tamoxifen or letrozole. And if they have HER 1 and 2, then we can opt for Herceptin. So these can increase the survival rate and also decrease the fear of that mastectomy that generates in the women. So these can be decreased to a great extent. So we're not doing a modified radical mastectomy nowadays. We can go in for oncoplastic procedures, which is much the top of the day.
Yeah, so we may do a quadrectomy or central quadrectomy. There are two techniques available. Basically, we need to put the nipple in the center and do a correction symmetry so that the osmosis is maintained, and then followed by chemotherapy and radiotherapy as and when required. And this case is to Dr. Amrita, a 35-year-old female, para 1, delivered 2 months back, came with a pain in breast.
Yeah, we have done this.
I've already done this. Yeah, there are a few questions. No, there are some questions which I want to talk.
No, she has already answered them, Anju. You are not online.
This is also similar case of a 54-year-old lady, clinically mastitis and inflammatory, found to be a malignancy, and the rough orange peel skin has already been told. Stages, we all know that all these inflammatory breast cancers are very virulent, and they are diagnosed very late in the 3rd stage, and they involve the skin. If it is spread to the outside breast, it is stage 4. And survival rate for all the inflammatory breast cancers are very low. You know, the 5-year survival of all inflammatory breast cancers compared to other cancers is not good, because they grow very quickly and more likely to spread at the time of diagnosis, and outcome is usually very bad in these cases. So 5-year survival, as we see in this table. Early detection can only in first stage, the survival is 96%, but when it is all the breast cancers
can you
we are
just
talking about
skip
here,
it, because we have already over time now.
No, it's my last slide, 1 or 2 slides. This is my last takeaway slide, 1 or 2 slides only left. So we all know that if the early detection is there, the survival rate is as high as 96, while in 4th it is only 18%. So the inflammatory cancer, we must do a mammogram, ultrasound and MRI, and sometime take a photo so that we can know what is happening in the future. And these are the few of the pictures, and then the biopsy and further management has already been discussed. So no, I'm not going into the details. And breastfeeding, there is no question of transfer of malignancy, but because of chemotherapy and hormone therapy, we may be worried. And opposite breast, if it is not affected, we can continue breastfeeding. And regarding the contraception, these survivors who have received tamoxifen are at a very high risk of endometrial hyperplasia, endometrial malignancy. So progesterone is have to be prescribed. LNG IUS is the best in these cases. And breast cancer survival should wait at least for 2 years after completion of treatment before planning the next pregnancy. Now, the reproductive outcome after treatment in these cases, chemotherapy may damage their ovary and may lead to transient or permanent infertility loss. And though most of the breast cancers are in the later group, it can be in a younger group. So these things we must know, as Dr. Shobna was just giving example of a case she is knowing. Though there are high level of estrogen known to increase the risk of breast cancer, it is proven that pregnancy and breastfeeding does not increase the risk of recurrence. This is the last case to Dr. Shubha Sethi. It's one very short question. 60-year-old female presented with nodularity in the breast, no history of breast cancer, no previous mammograms available. This is a film.
Okay.
Dr. Shubha, are you there?
Yeah, I'm here.
Yeah.
So any 60-year-old female coming with a lump in the breast, so the chances of malignancy in these are more than 25%. And so we have to treat them as potentially malignant. And the treatment in any case would be the biopsy that we have to do should be an excision biopsy in these cases. But before that, we have to investigate the patient, that is mammography. If needed, sonomammography should be done so that we know what is the actual state of condition. That is it localized to this area? Has it spread to the other breast, etc.? So that we can plan our treatment. But ultimately, in this case, like what we are seeing is a cystic mass with a solid protuberance over here. So any cystic mass with a solid protuberance is always potentially malignant, and therefore a excision biopsy of this case is needed. And therefore we must do a excision biopsy in this patient.
Yeah, very well said. So the critical message for today's whole webinar is that millions of precious lives can be saved if the woman follows the simple plan. Self-breast examination once a month after the age of 20, clinical examination once a year after the age of 30, mammogram once in 2 years after the age of 50, mammogram once a year after 60 to 70 years of age, and every obstetrician and gynecologist has a window of opportunity to examine all the females' breasts, and so we are privileged to diagnose breast cancer at the earliest. Mammography every year, and Indian guidelines still are evolving because of the expensive test. Imaging is must for all the lumps, and USG guidance is must for all the FNACs and biopsies. So breast is a knotty structure, and early detection saves lives. With this motto, I give thanks to Dr. Shobna Mundas. I did not spend a minute extra saying, recognizing the presence of all the senior people in the panel. And I am sorry that I mentioned nobody's name because of the shortage of time, but I am privileged to be there today. Privileged to be there, seeing Dr. Meeta being there at this time also, and all seniors being there at this late hour also.
Anju Didi, can we take this opportunity to invite everyone to Jaipur for our zonal conference?
Of course, of course.
So I extend my invitation to all of you to be pleased here with us for the zonal conference.
Yes, we can do that. We're all coming to Jaipur, but would anybody in the audience like to speak on the wonderful panel that Anju has just finished? And the mammogram doesn't have to be done immediately after 40. Now you're saying 50 is the age limit, right? Now the new guidelines have come.
Ma'am,
Yes.
as far as Indian guidelines go, still 40.
Yeah, internationally we are doing, but in Indian data we are trying to be more conservative because of the non-availability of the test and the cost factor, of course.
Okay. So it's after 40.
Yes, ma'am, because in India, the breast cancer incidence is earlier. The age group between 40 to 50 years, we are finding a large number of cases. So they say we must do screening after 40 in India.
तो ये 50 वाला स्लाइड क्यों लगा दिया?
क्योंकि इंडिया में पैसे नहीं है ना खर्चने को.
We have Indian guidelines. Why do we worry about what foreigners are talking? Anyway,
Yeah,
it's after 40 so far as far as we are concerned.
High risk cases we can take them earlier, but if
you said that we should not do mammography, only ultrasound in the young women because they have a dense breast. What about girls with small breasts? Should we do that? I'm not asking a naughty question. I know that.
Yeah, in cases of girls, normally we all know that all the lumps are very rare below the age of 14. The lumps are only seen after the age of 14. That was my first slide of presentation. I don't know you remember it. Even fibroadenomas are very, very rare below the age of 14. So
we continue to do ultrasound below 30, right?
Yes, yes.
Okay.
But in master checkup, they include mammography right from the age of 30 plus.
Dr. Repi,
In all
corporate
hospitals.
master checkup mein mammogram is there.
Ma'am,
We
in
don't have
young
mammogram
children,
in our hospital, so we don't do master checkup mein mammogram. I don't know.
Yeah, that is,
Madurai, it's there like that?
that is corporate driven, not.
Yeah, it is corporate.
Yeah,
Yes,
it's corporate driven.
They include all tests.
Meeta, you have a mammogram machine in your hospital, most probably. So are you also corporate driven to do mammogram at 30?
No. That is one thing which I stayed away from Shobhana, for the simple reason that it's not the machine, it's man behind the machine. And if you don't have good, radiologist, you will get into more trouble. So I always refer for my mammograms. I have a DEXA machine.
I know you have an examination. I thought you buy all the machines and keep.
I mean, I avoided buying a mammogram only for the simple reason because to get a good person to stay with you only for your mammograms is very difficult. Better to send somewhere.
And they'll scare everybody. Mammogram reports, they'll write BIRATS grade 3 and bus patients ka ho gaya khatam. You don't know what to do. They go on doing mammogram again and again. Whether BIRATS grade 3 is also corporate driven, I don't know. So that's really, they can't make out, so they say BIRATS grade 3. That's the worst part. Seema, you want to say something? Is it corporate driven, BIRATS grade 3?
Seems so.
See, in Madurai, Rotarians have donated one van with mammography machine, and we plan to take it to the villages and do a screening. Is it worth it?
I don't know. One Rotarians had come with a van to our hospital also, and they couldn't finish the number of women who went there, and they had to run away because the queue did not get over. So many people coming there for that.
The only thing, you should have a good radiologist who is expert in this.
Exactly.
So you don't end up giving false positives or false negatives. Either way,
exactly. Exactly.
All positives are also bad.
So according to me, first line is always self-breast examination, clinical breast examination, and then further.
That's true.
Dr. Shada, can you mute yourself? You are disturbing everybody. Please, thank you. So I put lot of importance on self-breast examination and clinical breast.
But using the flat of the hand is very important.
Yes,
they should not end up.
Teach our patients how to examine the breast. All the women.
Yes, Meeta, you were wanting to talk something about all the other things of the earlier talks. Would you like to? I know it's late in the day, but would you like to still say that?
No, I wanted to address, I mean, if Dr. Anjana is here, probably she can address this question.
I don't know if she's there. Anjana, are you there? No, I think she's left.
Any oncologist over here, because Dr. Kanchan was there at that time, no? When she was, so I wanted to know what is her take on the Gale model and other risk assessment, simple tools, where the woman can do it before you move on to the breast examination. So she misunderstood. She thought I'm talking about mammogram. I'm not even talking about mammogram.
Can you just explain the Gale model once more,
Nowadays, a handheld machine has also come up.
Pardon?
A handheld mammography machine is also come up.
Yeah, no, see, those are all not yet really validated in any population. Nobody talked about it. You see, the Tata Memorial has come up with such a fantastic paper, which Madam was talking about. Otherwise, in between after those Singapore, Japan and some other place, they came out saying self-examination is of no use, and the Europeans and the Caucasians kind of gave it up. But we cannot. The Tata Memorial have proved beyond doubt that self-breast examination by the clinician in India is very, very important. We are not at all anywhere close where we can just, do away with this. But before that, as a practitioner or as a woman in any forums, you start asking them, teaching them how to do the Gale risk assessment, which is online tool. So you just fill up a few questions and you get the risk assessment. So a person knows what is the risk for this cancer over a period of 5 years, over a period of 10 years, over a lifetime. So if it is there, if they're falling in the high risk group, they immediately go to the doctor, and then you can further segregate the groups. If you're low risk, you're more comfortable. So, and of course, that becomes very important in menopause for your hormone therapy. So two things. One is for
so we must teach the public to say that when you are looking at which film star is having which divers, instead of that, at least go and type Gale model once before in between you finding out that this diverse rates of film stars. You just find out whether you have a Gale model risk of breast cancer. Then you look at the next news on the internet, right?
Yes, then people will start doing it. Then people will start doing it. No, they want to know what is this Gale model because the film star has done it.
उसका साथ एक कोई फिल्म स्टार का फोटो लगा दो तो वो लोग देख लेंगे.
और क्या, बिल्कुल सही. Maybe we should get some film star to talk about it sometime, and then that will really.
They listen only to film stars.
Dr. Meeta, they don't come without money. The film stars don't come without money.
Yes.
And do you think they have that much intellectual left?
They don't have that. They don't have intellects. That is there. Very few of them.
Yeah.
I mean,
One question. Dr. Leena wants to ask one question. Yeah, Dr.
Please.
Madam, I wanted to ask you, what is your view regarding the thermography? We had some hand-held machine.
Yeah, that is thermography.
That is what
thermography. That is what I was talking.
Yeah.
I bought that machine. It was a waste. It doesn't give any conclusive evidence.
Yes.
So it's just lying in my cupboard like that.
Exactly. Thermography is not a sensitive
money.
one. The sensitivity is not good.
No,
with
not
thermography.
Yeah.
13,000 rupees to buy it, a waste of money.
No, we were given free of cost.
It is okay. I was like a fool. I went and bought it.
In Bhagalpur, it was given free of cost because still we don't have a proper mammography unit in our Bhagalpur. Only one person is doing that. Is also not. I think it is not that proper. So we have to send all of our patients for mammography to either to Patna or to Kolkata.
My God, and Patna distance is so big.
And we are more comfortable with the clinical breast examination and the self breast examination.
USG ultrasound. I think
ultrasound is there. Yeah, ultrasound.
So it is here that Gale score is useful, because if you do the Gale score and tell them the risk factor, I think they would be convinced to go to a higher center wherever it is available.
No, since we have started that
Sari over their forehead. I don't know.
Madam has started that registry now. We have started doing that Gale model, and we are segregating such patients.
Oh, excellent, excellent. So satisfying, Pratibha. Especially when you don't have a mammogram.
Yeah.
So thank you so much, all of you, and thank you, Shobana, and
thank you, Meeta, for being there till the end and
you.
Galing the Gale score.
Over to Dr. Roli. Dr. Roli.
Thank you.
Yeah, now you can invite people to Jaipur if you like. I mean,
we would be happy to have all of you with us, and that will make the scientific deliberations also more interesting. So we really want you all to be here with us. Meeta ma'am, we are requesting you also again and again. Shobna ma'am will always be there with us, and we are really happy that she has consented to be here with us. But Meeta ma'am, we request you again to take out some time for us.
Dr. Meeta is loud out.
When are the dates, Shubha? Dr. Shubha?
24th and 25th September, and on 23rd September we are also having a guided tour of Jaipur city, followed by a dinner at one of the village resorts, that is Chokidani.
From our eyes, the guided tour through our eyes.
So Shubha and Anju will guide you through a village.
So just have a taste of Jaipur and feel of Jaipur by coming over here. You'll find it a beautiful place and good for your shopping and everything too.
And all the best, ma'am. All the best.
Dr. Meeta, your shopping is old now. You came in 2016. Yeah, I know. Thank you
Yeah,
very
it
much.
better be good.
Amrita, thank you very much.
Otherwise, Gorakhpur will catch your ear.
Yeah, of course.
Gorakhpur is now in November, no? When?
So, Amrita, that is why I'm coming to your place.
Okay, Dr.
Okay, bye. Thank you. Eagerly
Bye.
waiting
Good
to meet
night.
you all. Bye.
Bye,
Bye.
everyone. Bye.
Bye, Revati madam and everybody else. Whoever is
Bye.
logged
Just a
in.
minute, madam. Vote of thanks we'll have. Yeah.
Yeah, sir.
I request our secretary, BMS, Dr. Archana Jha to please give the vote of thanks.
Pranam to all. I am overwhelmed to have this webinar in our society, and I'm really grateful to Sobna ma'am for giving this opportunity to us, and I'm really grateful to Dr. Pratibha, our president, to bringing this webinar, important webinar in our society. And so a galaxy of brain and beauty are involved in this very prestigious and knowledgeful webinar that enlightened our knowledge about the breast and its different aspects from the childhood to the menopause, and how we can manage these cases. And Sobna ma'am has a wonderful thought on the HRT and use of in the menopause and breast disease, and we can use the HRT in even that patients also. And also as we gynecologists fear about giving HRT to our patient because of fear that it will enhance the breast disease, but as we all know that it will enhance the diagnosis and it will be earlier, and the lower grade of breast cancers are seen in these HRT patients. And I must thank our chief guest, Dr. Meeta ma'am, for being with us for so long, and our guest of honor, Dr. Ambuja ma'am, and our president, Dr. Sobna ma'am, for we are really appreciate your gesture every time we are encouraging us to having participating in this webinar, and also transference. That is the very encouraging and very true for us, most needed thing for all of us. Thank you, Soni ma'am, Anju Soni ma'am. It is one excellent panel on breast mass. Every aspect is dealt with so clear vision and so important messages that we need in our day-to-day practice. And we all know all these things, but we have to implement this. I am in our medical college. I am teaching our every student to examine breast and about the importance, and it will help them to diagnose timely, and also teach our patients also how to do and when to catch your doctor, and how you will be saved from this disease. And every finalist, all the great personalities full of wisdom and clear concept. Thank you, Dr. Ragini ma'am. Always.
Archana, you're muted. Archana, you're muted by chance.
Okay, ma'am. No, it's okay. Yeah, Dr. Ragini ma'am, Dr. Amrita ma'am, Dr. Leena, Dr. Subha, Dr. Anupama, Dr. Vasundhara, all our dear ones. And actually all the persons are so much popular among us, and we appreciate you all for
I am very, very thankful to all the IMS members who have joined. There were a lot of senior doctors who were there. I could see them. Dr. Vandana was there. I mean, the attendance was very, very good. Thank you. Bhagalpur were working so hard. Thank you very much.
Thank you so much, madam. And really, we are privileged to have you in this webinar. Thank you, President ma'am. Thank you, Secretary ma'am, and thank you, Pratibha, for having this webinar in our society.
Thank you, Seema, for being there
all your effort.
Dr. Seema Sharma, madam, thank you so much.
Thank you, Rolly, for having a good moderation and support. Planet People for providing us this platform and for flawless presentation of all the time. Thank you so much, all in. Namaste.
Thank you so much. We are closing here.
Bye bye and good night to everyone.
Okay then, bye.
Bye.
Bye.